Let's begin.
Would you like a random test, or would you prefer to focus on a specific subject from the SCORE curriculum?
Random, please.
Patient STEM, a 61-year-old male, presents to the emergency department with a 2-day history of worsening left lower quadrant abdominal pain, subjective fevers, nausea, and one episode of vomiting. He has a history of hypertension and hyperlipidemia. He reports no prior episodes of similar pain. On exam, he is febrile to 38.6, heart rate is 108, blood pressure is 123/68, and he appears uncomfortable. Abdominal exam reveals significant tenderness and guarding in the left lower quadrant with mild distension. Laboratory studies show a white blood cell count of 17 and creatinine of 1.2. A CT scan of the abdomen and pelvis with IV contrast demonstrates severe sigmoid diverticulitis with a 4 centimeter pericolic abscess, extensive pericolic fat stranding, and suspicion of a contained perforation. There is no free air, but localized fluid is present. What would you like to do now?
Thank you. This is a 61-year-old male presenting with severe complicated sigmoid diverticulitis. He is hemodynamically stable but uncomfortable with localized peritonitis. My immediate actions are to ensure IV access, monitor vitals, place him on NPO status, and begin IV fluids and broad spectrum IV antibiotics. I would monitor his urine output via a Foley catheter. I would clarify his history further to look for previous episodes, any changes in bowel habits, any allergies, anticoagulation, current medications, etc. On physical exam, I would carefully assess for a generalized peritonitis, any signs of sepsis, and I would perform a rectal exam. My differential currently is complicated diverticulitis, but could also include colonic malignancy or any other source of intra-abdominal infection. Also, if available, I would ask IR to evaluate for percutaneous drainage of the abscess given its size.
The patient's abdominal exam progresses over the next 8 hours with increasing pain, worsening, tachycardia now at 120, persistent fever, and the development of diffuse peritonitis on exam. There is now evidence of clinical deterioration and generalized peritonitis. What is your management at this time? Please outline your operative plan.
Well, given the development of generalized peritonitis and clinical deterioration, I would proceed with an urgent XLAP. I would obtain informed consent for the possible Hartmann's procedure, a colostomy, and discuss potential risks, including injury to adjacent structures.
Describe the key steps and critical anatomic considerations in performing a Hartmann's procedure for this patient. What specific strategies do you use intraoperatively to identify and avoid ureteral injury during this operation?
My operative plan is as follows. I would perform a midline XLAP. I would explore the abdomen to identify the site of perforation, the extent of contamination, and rule out any other pathology. I would control gross spillage with laparotomy pads and establish exposure. I would mobilize the sigmoid colon and identify the disease segment. I would skeletonize the mesentery and secure the marginal artery. I would carefully dissect the left ureter to prevent injury given the inflammatory process. I would resect the sigmoid colon distally to ensure that there is healthy margins. I would oversew the rectal stump and leave a long tail. I would perform an end colostomy with the proximal descending colon, irrigate the abdominal cavity thoroughly, and assess for hemostasis. I would leave drains, and then I would close the abdomen in standard fashion. Throughout this, I'll be vigilant for intraoperative complications, particularly a ureteral injury, and address any unexpected findings. I would ensure that pathology is sent to rule out any underlying malignancy.
During your dissection and mobilization of the sigmoid colon, you inadvertently transect the left ureter approximately 6 centimeters above the pelvic brim. The ends are identified, and there appears to be sufficient length and viable tissue for primary repair. How do you manage this ureteral injury? Please describe the specific repair technique you would use at this location.
Well, typically I would consult urology in this situation, but if they are not available, then I would proceed with a tension free, spatulated end to end ureterostomy over a ureteral stent. I would ensure both ends are viable with a good blood supply and no devitalized tissue. I would sharply spatulate the ends of the ureter. I would insert a double J ureteral stent. I would perform the anastomosis with interrupted absorbable sutures, taking care to avoid narrowing the lumen. I would place a closed suction drain adjacent to the repair to monitor for urine leak. and then I would proceed with the remainder of the colon operation as planned, minimizing dissection near the ureteral repair. Postoperative care would include monitoring for urine output, serum creatinine, and imaging as indicated.
After completion of the Hartmann's procedure and ureteroreterostomy over a stent, the patient is transferred to the ICU for ongoing management. On postoperative day 2, the patient develops increasing abdominal distension, tachycardia, leukocytosis, and bilious output from his pelvic drain. His creatinine rises to 2.2. What is your differential diagnosis for this clinical scenario, and how would you proceed with the evaluation and management?
Hmm. My differential diagnosis includes an anastomotic leak from the rectal stump or the residual bowel, perhaps an injury to the bowel itself during the repair, urinary leak from the ureteral repair. Biliary leak needs to be on my differential given the color of the output, though this is less likely in this case. And then, of course, an intra-abdominal abscess that would contribute to an ongoing sepsis picture. To evaluate, I would send drain fluid for creatinine, amylase, and culture. I would obtain a CT scan of the abdomen and pelvis with oral and IV contrast, and would consider getting a CT urogram at the same time to evaluate the integrity of the ureteral repair. My management, of course, will depend on these findings.
Imaging and drain creatinine testing confirm a urinary leak from the left ureteral repair with a moderate fluid collection but no generalized peritonitis. The patient is hemodynamically stable. What are your next steps in management for this postoperative urine leak? Please describe both non-operative and operative options and how you would decide between them.
Well, in this hemodynamically stable patient with a moderate urinary leak from the ureteral repair and no generalized peritonitis, I would first pursue non-operative management. I would get adequate drainage of the urine collection and possibly arrange for IR placement of additional percutaneous drains. I would consult urology as well if they are available in my facility. I would maintain broad spectrum IV antibiotics, monitor renal function, fluid balance, and output. If this non operative management fails, then the operative intervention is warranted. Those options would include re exploration with revision of the ureterostomy, a possible ureteroneocystostomy with or without a psoas hitch, or a temporary urinary diversion with a nephrostomy tube.
The patient's urine leak is controlled with percutaneous drainage and antegrade stenting by interventional radiology. Over the next week, his renal function stabilizes, the drain output decreases, and he shows no further signs of infection. He is transitioned to oral antibiotics and begins gradual recovery. What are your key considerations for this patient's ongoing management and follow-up regarding both the colostomy and the ureteral injury? Please include long-term surveillance and timing of potential reversal procedures.
Well, for the colostomy, I would provide comprehensive stoma care, education, and support, including involvement of a wound ostomy nurse. I would plan for colostomy reversal typically about 3 to 6 months afterwards to allow adequate recovery. Prior to reversal, I would perform a contrast enema or flexible sigmoidoscopy to assess the rectal stump integrity and rule out any strictures or leaks. For the ureteral injury, I would coordinate with urology for surveillance of the repair and maintain the stent in place for about 4 to 6 weeks. I would obtain post-stent removal imaging to confirm patency of the ureter, exclude hydronephrosis, and ensure normal renal function. I would also need to monitor for potential complications such as ureteral stricture or recurrent urinary tract infection.
Your oral board exam is complete. Your test data has been stored. You can review your performance on the performance page or start a new test using the Generate New Test button. Can I help you with anything else?
No, thank you very much.